Okay, now let's start the PVI isolation. I usually start from the left side upper pulmonary vein and the anterior ridge because this location is the most important part of PVI isolation and the high recurrence in this area. As I told you during the explanation, the teaching video, the distance between the schist tip and ablation tip is important. If it is too far away, the contact force is reduced. If it's too short, sometimes you make too high temperature and risk of complication. So adjust the contact force is very important. Even though the tacticat catheter or the smart touch catheter can monitor the contact force, but I prefer to use the flexibility catheter because flexibility catheter generate a bigger lesion and the temperature thermal sensor is located at the tip of the catheter. So even though we cannot believe the tip temperature during using the irrigated tip ablation catheter, but some degree the temperature reflects the tip temperature when I use the flexibility catheter. So I prefer to. It is my favorite catheter to ablate. And nowadays I'm using the 50 to 60 watt hyper short duration ablation. And with the 50 watt ablation, in the anterior aspects of pulmonary vein, I usually maintain 10 to 15 seconds. But it depends on the patient body size and gender. If the old lady with small size heart, I reduce the duration of ablation less than 5 seconds sometimes. So far, I use the hyper short duration ablation more than 300 cases, but so far, in my experience, is pretty good and safe. But the posterior aspects, you have to be very, very careful.
Even though the hyper short duration ablation make a surface burn, not a deep burn, and broader lesion generation, but the left side the posterior wall is still very dangerous area because there are many critical structures contact with LA posterior wall, especially esophagus, aorta, and vertebra. So when I try to ablate the posterior wall, I usually deliver less than 50 watt and left less than 10 seconds. And if patient complain pain, I stop burning and move to another position. And I think the monitoring of esophageal temperature is mandatory. If you do not monitor esophageal temperature, do not use hyper on the posterior wall. And also, even though you monitor the esophageal temperature, if the temperature tip is there is a distance discrepancy between your ablation catheter and the temperature tip, this temperature does not provide you the proper information. So your catheter tip is away from the esophageal temperature probe. You need to ask your nurses and technicians move to this esophageal temperature close to the ablation the point. And I usually use cutoff value of esophageal temperature is 38.4 degrees Celsius. If it is going up, do not ablate. Just move another point. So I recommend to you ablate the posterior wall stochastically, not the linear continuous ablation, to give a chance to cooling down the esophageal temperature. So move at this point and other point, comes and goes, and finish up the ablation. And also, if there is a very small potential is recorded on the tip of ablation catheter, move the catheter rapidly to another point.
So in this point, the temperature is over 39. So I move on to the other point. So like a frog jump, I ablate the posterior aspects of the left side antrum. from here to away here, because we need to give a chance to cooling down of increase the esophageal temperature. So during the cooling period, the esophageal temperature, I generally added the linear ablation along the posterior aspects of appendage. As I told you, there is folded area between left side pulmonary vein and appendage, and in that area, the muscle thickness quite thick, like a funnel. So in the folded area, all those folded areas filled by muscular structures. So I added the linear ablation and the posterior aspects of appendage. Another reason for the posterior appendage, LA appendage linear ablation is to targeting the ligament marshal. Ligament marshal branches many nerve fibers to not only pulmonary vein aspect, but also appendage aspects. So that's why I give her the same high power ablation, short duration along the appendage posterior aspects. But please make sure if push your ablation catheter a little more. Free side of a left atrial appendage has very thin musculature with a lot of triangulation. So don't ablate inside of appendage. Just appendage ostium, the posterior aspects is my target. Let's move back to the posterior aspect of atrium, left side antrum again, and ablate with monitoring the esophageal temperature. The roof aspects of pulmonary vein is hard to approach because sheath is already inside the pulmonary vein with natural curve. In that case, I already told you make a second curve ablation. So watch the fluoroscopic image. Okay, push the ablation catheter inside of pulmonary vein and twist the sheath, make a second curve. And then your ablation target is matched to the antral area. If you make a second curve, don't try to change the catheter position and make a torque on the catheter. Just push and torque with sheath, not catheter alone. So I think this area include the septopulmonary bundle. It is a very thick and important bundle. Sometimes epicardial connection make the PV isolation procedure very difficult. So it is important to give enough energy. Sometimes patients feel pain in this area and the vagal response. And finish up the left side of PV antral ablation. Then I generally give the cranial line with 30 watt, very short duration. If there is no potential, I move, just checking the PV potential. You should watching the ablation signal continuously. So if there is no signal or very small potential, then you can move faster. But if it's huge signal, you can come back and give a more ablation ablation energy.